Hello, and welcome to Stanford Care's monthly community talk series. My name is Meenal Mahari. I'm occupational medicine physician and director for nutrition for Stanford Care. I'm really pleased to bring you this series of talk co-sponsored by Stanford Health Library and Vincent C. Wu Foundation. I'm very pleased to welcome Dr. Ranak Trivedi, who will be speaking on caring for family members with chronic or serious illness, roles, challenges, and coping. Dr. Ranak Trivedi is a clinical health psychologist and assistant professor in Department of Psychiatry and Behavioral Sciences, Stanford University, and an investigator at the Center for Innovation to Implementation at the VA Palo Alto Healthcare System. Her NIH, VA, and foundation-funded studies are focused on improving the self-management of serious illnesses by enhancing the collaboration and coping of patients and their caregivers. Dr. Trivedi is a Surgeon Scholars leader, and she is using this platform to improve culturally concordant care for South Asian women with breast cancer and their caregivers. Dr. Trivedi serves as Director for Training and Education at the Center for Innovation to Implementation at the VA Palo Alto Healthcare System, Site PIA, and Training Director for Elizabeth Dole National Center for Excellence of Veteran and Caregiver Research, and the Director of Caregiving and Family Systems at the Stanford Center for Asian Health Research and Education, CARE. She envisions a culturally concordant healthcare system attuned to both the patients and their caregivers. Here is Dr. Trivedi.
Thank you so much, Dr. Mahari, and thank you, Stanford Care and the Wu Foundation for supporting this series. And thanks all of you for taking the time out so late in the evening to attend this presentation. I'm just going to take a second to share my slides. So as you all know, we're here to talk about caring for family members with chronic or serious illnesses, the roles, the challenges, and coping. And I want to start off by saying that November is National Family Caregiver Month. So this is why this topic is really relevant for this particular month, and it'll allow us to have a conversation about how in the Asian context, these things seem to manifest. I have no financial conflicts of interest to declare for this presentation. I want to start off by telling you a little bit, and you probably already know this, but just to review what are chronic and serious illnesses. And chronic illnesses are those that last a year or more. So we all know what those conditions, some of them look like. There's hypertension, breast cancer can be included in that, depression. They're all conditions that can last a year or more. And those are chronic conditions. And these are US data, but I think it's important for us to anchor ourselves into how common these conditions are. In the United States, there's 59% of adults who have at least one chronic condition. And that is the figure to your left over here. 28%, so about 1 in 3 have 3 or more chronic conditions, and 12% have 5 or more chronic conditions. And what's striking about this is that 90% of our healthcare spending in the United States is for managing chronic conditions. So this is a pretty big deal when you think at the society level. But let's talk about Asia, which is something that I think is relevant to all of us who are on this call. Asia is, of course, a very big area that we're talking about. It's an entire continent that comprises 48 countries with 71 official languages, and it covers 17 million square miles. And yet a lot of times we wind up lumping people into the Asian category, even though that's 2/3 of the world's population. And I think this is important for all of us who are navigating the healthcare system to keep in mind that when we're talking about Asian health, anything, we're really talking an extremely heterogeneous and diverse group of people. And this is what it looks like. These are just some pictures of people who, all of whom have Asian background. So you can see the amount of diversity that the Asian diaspora or Asian natives bring to our world. And yet there are certain commonalities. So these are the deadliest conditions across South Asian countries, which are these 7 countries. And you can see the ones that are bolded are the most common, are the common across all the groups. And stroke, ischemic heart disease, and COPD, which is chronic obstructive pulmonary disease, are the most common causes of death in most of these countries. And then if you expand beyond to other Asian countries, again, you'll see stroke, ischemic heart disease, COPD, kind of repeated. So while there's a lot of chronic conditions and there's a lot of heterogeneity in the group of people we're talking about, there are certain things that are common amongst within this group of folks. Managing these conditions, chronic conditions, is really complicated. It often requires adherence to medications, taking medicines on time, often multiple medications, especially if you're managing more than one condition. A lot of times there are exercise recommendations. Sometimes they are tailored to the health condition. Sometimes they are about the minimum exercise you should be doing. Sometimes could be maximum as well. There's often dietary recommendations, could be low salt diet, low sugar diet. Certainly things like having more vegetables and fruit is something that we hear repeatedly. An important aspect of self-management of chronic conditions is monitoring symptoms. So these could be things like shortness of breath, or watching if your weight is increasing very rapidly, watching your fluid intake if it's diet. These type of monitoring symptoms is a critical aspect of many chronic conditions because it also involves knowing when you can manage it on your own and knowing when you need to call an advice line or go to the emergency room. Preventive care is an important aspect of chronic illnesses, and this could be things like taking the flu shot, now of course the COVID vaccination. So managing all these multiple things can be a very complicated thing. And in fact, by not managing these properly, it can lead to worsening health and lowering the well-being of the person who is managing these health conditions. In addition, because these are so complex and very hard to manage sometimes and remember all the different things, it can also increase the risk of depression if you have too many health conditions that you're managing. And that is where caregivers come in. Caregivers are family members and friends who care for somebody with a medical or mental health condition. And in the US, there are 53 million adults who identify as caregivers according to national data. What is striking is most of the time, people are not paid to provide this care. So if you think a husband and a wife or a son caring for a father, these are not positions that people get paid to do. But if you take the amount of unpaid care that is provided in the United States each year, it is estimated to be about $500 billion. Now, I don't know about you, but that is a really large number for me, and I cannot wrap my head around it. So I will try to anchor it with some of these very familiar multinational companies, and these are the market caps of these companies. So as you can see, the unpaid services provided by caregiving exceeds the market cap of 3 Fortune 100 companies. So basically, if caregiving was an industry or a company, it would be a Fortune 100 company. These are some important statistics of what caregiving in the United States looks like. And again, this is not Asian specific. This is generally in the country. These are reports that are put out every 5 years by AARP and National Alliance of Caregiving. And you can see that in the top left over here, the number of caregivers between 2015 has increased by about 10 million by 2020. Now, it's important to remember that this report actually reflects pre-pandemic data because it's the report that came out in 2020, but the data were collected in between 2016, 2017, 2018. So these numbers will be very interesting to see the 2025 report to see how much of that shifted because of the pandemic. What's striking is more Americans are caring for more than one person, so it went from 18 to 24%. From 1 in 5, it's now 1 in 4 people have difficulty coordinating care. There's more people caring for Alzheimer's disease or dementia, and more family caregivers are reporting that their own health is poor. So not while they're caring for somebody else, their own health is getting worse. Caregiving can be a very gendered situation. In this, as you can see, 61% of caregivers are women, but of course that means 39% are men. So really caregiving is something that is an everybody issue. And then about half report that being a caregiver has had at least one financial impact. And 6 in 10, about 3 in 5 report that it's had an impact on their work environment. But caregivers are really critical to self-management. Caregivers like husbands, wives, sisters, daughters-in-law, daughters, sons, you name it, they play multiple roles. And what we know from a few decades of research is that people who have caregivers involved have generally better outcomes than those who don't. Caregivers provide emotional support, so help with coping with the patient who might be struggling and help with stress management. They provide what's called instrumental or practical support, so they help prepare meals, pick up medications, all the way to taking care of things that are called activities of daily living, like helping somebody take a bath or assisting with mobility. Increasingly, we are expecting the caregivers to take on really complicated medical tasks. This could be things like wound care, so dressing changes, or giving injections at home to patients. These are usually tasks that previously were taken care of by nurses or nursing aides, and now we're expecting caregivers to take on these tasks. And then caregivers are very critical to care coordination, for example, understanding discharge instructions. This is a lot that caregivers are expected to do, so it's probably not surprising that it comes at a great emotional and financial cost. On average, caregivers pay about $7,000 out of the pocket every year to care for the care recipient, and these could be, picking up groceries, helping pay for medicine, gas money to drive to appointments, and helping with rent, anything. And the emotional toll taken by caregiving actually increases with the amount of time people provide care, as well as the intensity of care provided. And then finally, caregivers also take on patient advocacy, so representing the voice of the patients in the healthcare decision-making. In the same report that I mentioned earlier with the National Alliance of Caregiving, they actually looked at the characteristics of Asian caregivers. And again, we all know on this call that that's a very diverse group, but these are the data that we have. On average, the average caregiver who identifies as Asian is about 49 years old, and they care typically for a parent or a parent-in-law. About half live with the care recipient, and the care recipients often are about approximately 70 years of age and have about 2 health conditions. What's striking is that they provide 24 plus hours of care each week. That is more than a half-time job. So in addition to working about a full-time job, which is the next bullet point, our caregivers, Asian caregivers, are providing another 24 hours of care. So they're basically doing a job and a half when they are caregivers. Compared to other racial and ethnic groups in the United States, Asian caregivers actually report way higher emotional distress. And strikingly, majority feel that they had no choice in taking on their caregiving responsibility. They felt that they were expected because of their relationship and the cultural norms that they had to take on these different caregiving responsibility. They didn't have a choice. And they also expect to be a caregiver for someone else, so another person in the next 5 years. So while Asian culture is very diverse, there are certain commonalities that manifest in this caregiving world. An important part is that Asians are collectivists, meaning that the cultural norms are that the group is prioritized over the individuals. And so people are expected to take care of other people and think about what's best for the family, what's best for the community, rather than your own individual needs. And within that, the motivations and expectations are culturally embedded. So why people are caring for each other is because it's expected that if you're a daughter-in-law, you'll be caring for your father-in-law and your mother-in-law. It is not something there's much choice that is given in that. And the expectations could be that the son is actually taking care of the financial pieces, whereas the daughter-in-law takes care of all the other household chores. And this type of, there's a lot more intergenerational care that occurs in Asian cultures because kids and youth often get engaged because grandparents are cohabitating and the families are multi-generational. So there's a lot of intergenerational caregiving that occurs. We saw in the United States that about 61% of caregivers are women. So women are generally caregivers and across all cultures, but there are very rigidly defined gender roles that make a difference when it comes to caregiving out in the Asian countries. Unfortunately, we don't have really nice national data as like we do in the United States and Europe and Australia. But there's an estimate that in India, 80% of caregivers of middle-aged people, or sorry, not middle-aged, people who are 60 and above, 80% of those caregivers are women. So 8 out of every 10 are women. And often these are daughters-in-law, not daughters. There's also some concepts that in caregiving that are important to think about. So for example, in some of the Indian culture, especially in Hinduism and Sikhism and other religions, there's this concept of seva. And seva, the concept is really translated into service. But in this case, the idea is that service to another person who is in need is the same as serving God. So it's considered a spiritual experience or a spiritual practice. And the way it's, when it works, it makes people feel less guilty that they're not devoting their time to prayer or meditation or other religious practices. But as you can imagine, when you're told that this is something that you should feel good about, but you're actually feeling stressed and burned out, people don't feel that they have an avenue to share these negative experiences. And of course, we're all familiar with health literacy and language barriers as in the healthcare system, because we don't have materials that are in Asian languages, and they're not culturally concordant. And finally, help-seeking behavior also varies. So Asian Americans are less likely to seek professional help when they are under stress. They're less likely to tell their doctors or get help from a mental health professional. And they do need help with managing emotional, physical stress. But other things that people in Asian cultures often are looking for is finding a home care agency or residential facility, especially one that can speak the language or has the culture of the person that is being placed in the settings. Pardon me. I mentioned that the caregivers in the United States are experiencing significant stress, and this is likely the same in Asian cultures as well. And while we don't have, as I mentioned, nice national data, there have been a few studies, and this particular study looked at caregivers in India. And they found that 2 out of every 3 caregivers spend more than 10 hours per day caring for their patient. More than 50% reported depression, so more than half reported that they were feeling depressed. And they were more likely to report depression if they were caring for a spouse, if they were living with the patient, so I guess they weren't getting a break. If they were responsible for household chores, money, and transportation, and provided more than 10 hours of care per day. And in this particular study, it was striking because everyone reported stress. So 18% reported severe stress, but everybody's reported at least moderate stress. But I don't want people to feel, that it's all gloom and doom. People do experience significant joys of caregiving. And I think it's important for us to recognize that there's all of these activities, there's ways in which we can bring about joy. In one study, they found that 83%, so that's a pretty sizable number, 8 out of every 10 caregiver experienced some positive aspects of caregiving. And it's been documented that if you're a partner, if you're a wife or a husband or a girlfriend or boyfriend, you are more likely to feel caregiving joy compared to other relationships. So compared to like if you were a child caring for a parent. What are some sources of positive effects? People feel that they feel a reward of helping someone in need. They feel that they're doing the right thing by helping somebody in need. Caregivers report that they feel the positive aspects of growing. They feel that they're growing in the role. They're able to take on more responsibilities. And a lot of caregivers engage in what is known as benefit finding. So they think, what is the benefit of this challenging situation I'm going through? And people say that they feel they get more time with a loved one. They feel that there's more meaning and purpose in their lives because they're being they're contributing to somebody's life. And a lot of them say that they feel good because they feel that they're modeling for the next generation how you should care for each other. To me, this is a very personal aspect. So this is not something that is just a hypothetical for me. These are my parents. My dad so we grew up in India, and my dad, like many people from South Asian countries, has long history of early onset of a heart disease. And my mom is a breast cancer survivor. She's taken for over 10 years, over 15 years of that, she's had metastatic breast cancer. And I've seen firsthand how in our families, not only are they caring for each other with each other's health conditions, but how so many family members and friends have stepped in to help out during the most acute phases of this disease management, and how people really focus on the person who is in need of help. And I think it's very important to recognize that these are real stories that we are talking about. But I've also seen when things have become challenging, where one of them feels like they're kind of gotten to the point where it's been so stressful that they need a break. We've been very fortunate that there's a lot of people involved, but we know that that's not always the case. So my goal is to eventually develop a culturally attuned, family-centered healthcare system to support patients with chronic and serious illnesses. And I'm going to share some of our own research at a very high level, and I'm happy to answer questions about this too, just to sort of highlight these important issues. So this study is called SAFAD. SAFAD means succeed in Gujarati, which is my mother tongue, and it stands for South Asian Family Approaches to Diseases. And the idea behind the study is that I mentioned my family history, and I really wanted, when I started digging, I realized that there's actually very, very little research on family caregiving in South Asian countries or in Asian countries in general. So our goal was to first, and even the experiences were not understood. So what we wanted to understand the experiences of South Asian survivors of breast cancer, as well as their family members and friends, so their caregivers. We also wanted to talk with providers to see what can the health care system do to address the cultural needs of South Asians managing breast cancer. And our eventual goal is to develop programs that can address these unmet needs. This is our website. So we've completed phase 1 of interviewing, and I'll share some data or share some results from that. But you're welcome to go check it out at SAFAD Study sites, or you can get the QR code or just email me, and I'm happy to direct you that way. So what we did was we interviewed 13 survivors and 13 caregivers. Survivors had had breast cancer for, on average, about 5 years. And survivors and caregivers were in their 40s, so they were on the younger side. And what we did was we interviewed them, and they participated in about an hour-long interviews as well as complete surveys. And these are just some of the findings that resonated, that we saw across these interviews. First, we found that survivors and caregivers really wanted to connect with other South Asian survivors and caregivers. Cancer is a very stigmatized condition in South Asian culture. So when cancer is diagnosed, it becomes very isolating. So they felt that, well, who would really understand or they really could talk to is people like them. We also found that survivors and caregivers had high trust in medical teams. However, caregivers did feel that the healthcare teams were not engaging with them as much as they could have. Both survivors and caregivers said that they wanted culturally concordant lifestyle recommendations for managing cancer. So for example, they wanted to know what are some things that they could do to prevent recurrence of cancer, or now that they've had cancer, what is it that they can do to improve their prognosis? And the challenging part of this is actually when we talk with oncologists, there aren't really any lifestyle recommendations once you develop cancer. There are things you can do to prevent cancer: exercising, keeping your body fat down, not smoking cigarettes, alcohol, limited alcohol use. But once you have cancer, there are no recommendations. But the South Asian families really wanted to know what kind of meals should they prepare? What kind of food should they eat? And they didn't really get any answers. Caregivers noted that they were caring for many individuals, not just the person who had breast cancer. And they did say that they received a lot of emotional support, but what they really wanted was practical support. They really wanted somebody to help with meals. They wanted somebody to take the kids to school. They wanted somebody to take the patient to the different appointments. And then finally, and this will probably not come as a surprise to anybody on this call, that people really didn't find culturally concordant any tools or materials, educational materials, that could help them in their own languages. We also asked our participants, what are some things you need to take care of yourself? We were really curious, and this was just a narrative that they provided. So what we did was we put these answers together in a word cloud. And as you can see, what they really wanted were friends and positive people and support system families. So what they really, really wanted was to connect with other people. That was their top needs. And when you ask the same question of caregivers, they kind of said the same thing, but what they really wanted was practical support. They felt that they wanted emotional support, they were getting other things, but what they wanted was mainly practical support and some family. And then of course, we hear this from caregiving research all the time, is they want just more time. They want time for themselves. They want time to just navigate everything. Somebody hears that alcohol, one of the patients said wine, which, fair enough. The other thing that we wanted to do, and this is something I think that what we're hoping to do with this is to make it into a tool that we can use clinically, is to adapt these tools called Atlas Care Maps. And these were developed by Raj, who is our advisory board member, and we've collaborated for a while. And he has developed these Atlas Care Maps to visually represent people's care networks. And we've been working with him to adapt it so that it can add different pieces that also are useful clinically, so that healthcare teams can use it. So we did this. What we did was we interviewed all of our participants, and we developed, based on the interviews, we developed the care maps with targeted questions. And I'll give you just an example of a survivor one and a caregiver one. And it's a way for us to visualize, and for the participants to visualize, what's existing in their network and what could be missing. So here's a survivor example. So this is a woman who's a breast cancer survivor. She lives in the house. These concentric circles represent geographical distance. So the darker gray means that people are living in the same city. The lighter gray is a different state. And then if you go beyond that, then they're outside of the United States. So she lives with her husband, and she actually provides care to him, even as he's caring for her. And he helps. These are different icons we've developed, but he helps. He prepares meals. He helps, does some research. He takes her to the medical appointment. The blue arrows going towards the survivor, towards the person, indicates the care that they are getting. So she gets support from her workplace, but it's kind of intermittent. It kind of comes and goes. She has a brother who lives close by, who she provides support to by talking, but he helps her mainly by doing some research, but really taking care of their parents. She has a nutritional therapist who kind of helps take care of some of her nutritional needs. She has some close friends who help out, who provide some emotional support, kind of helping with stress. She has her healthcare team. She also has a boss who's a breast cancer survivor, and some coworkers who also provide some care support to her. But she also supports her brother's kids. She's kind of talks with them and sort of helps them kind of get through their life stuff. But that's not all. She also supports her sister-in-law, a brother who she FaceTimes with, a mother who she supports who lives back in India, and a dad who she feels like she supports, but she also gets some support from her. So you can see that in this one person's network, there is just so much richness that does not get captured when we go to a clinic appointment. But if you can imagine that if you were to take something like this to your clinic appointment, then it would make a lot of sense for the care team to go, oh, this is what's going on in your life. These are a lot of people involved. So it's not just one or two people that we're talking about. So what we found that across the different survivors, that on average, the number of people the survivors supported were about 4. So they actually supported 4 people and received support from about 14 different people. So they were pretty rich and complex networks. Those who had earlier stage cancers were provided care to about 4 people, and that number dropped to about 2 people later in the later stages. And the survivors, compared to survivors who were less than 40, those were 50 and above, were more likely to seek support from individuals outside the US. Okay, so now this is a caregiver. Again, I'm just going to show an example. I think maybe you can follow along better now. So this is now the caregiver, the husband, same 2 circles, concentric circles. This is the wife. This is the same. So this is the same couple that I'm talking about, by the way. So you can see there's also going to be some differences in what they feel that they each do. They're caring for each other. We saw that. He gets some support from an aunt who's a breast cancer survivor who also shares some medical information. And he has found his brother-in-law's colleague who's a breast cancer survivor, who he also talks to and gets some statistics from and gets some information. He speaks with the brother-in-law. This is the wife's brother we saw in the earlier care map. And then there's another brother-in-law that he also talks to. So this is from his side, his sister's husband. He has his own care team as well. So you can see that compared to the survivor, his network is quite sparse, and he's only caring for the wife and nobody else. So on average, for caregivers, they reported that they had about 9 people in their care network. They supported about 4 people, and they felt that about 8 people supported them. So a little less, receive a little less support than survivors felt. Also, we found that for caregivers, more than half of their care networks were composed of family members. And only 3 caregivers reported they felt supported by the care team. So these sort of represent that our collectivism that is so inherent in the Asian culture is actually deeply embedded in how people come together when they're caring for somebody with a chronic or serious illness. So to summarize, and I see there's the chat is active, so I'm guessing there's some questions coming in. So I just want to summarize by saying Asians represent a large, diverse group with some common values, whose caregiving networks include mainly family members, and caregiving is often provided by women, although as you saw in the data I presented, men are also often providing care as well. And intergenerational care is very valued. I just want to put in a plug that caregiving, as with other aspects, it remains vastly understudied amongst our communities. So if you see opportunities to volunteer for research, please consider joining them. And we should note that caregivers experience both joy and stress in their roles. I'm going to just share some strategies that would, if you are a caregiver, or if you see a caregiver, some strategies that could help, and I am happy to expand on this some more. So a couple of the pointers I have is wanting to take breaks is normal, so don't feel guilty. If you feel like you've had enough, you need a break from providing care, that's an absolutely normal part of the experience, and it's helpful to talk about it. It's important whenever possible to communicate your needs and boundaries with the care recipient. So whoever you're caring for, to let them know when you need a break, what are things that you're comfortable doing and not comfortable doing, which are very complicated and difficult conversations. When possible, you should create a schedule that allows you to take breaks. And don't hesitate to get help from other family members, friends, or even nursing aides or home health aides who can help take care of some of the things at home. This can be challenging at times, but focus on strategies to increase joy, which include finding meaning in the work you're doing, finding humor, and then doing things with the care recipient that you enjoy. And this could be things like going for a walk, watching movie, watching TV, playing games. It depends on how much the care recipient is, how mobile they are and what they're willing to do. A lot of people find it beneficial if they talk with other caregivers or if they join a support group. And then finally, please always consider talking to your primary care provider or mental health professional if you start feeling depressed, stressed, or burned out. These are some resources that are really good to look into if you are a caregiver yourself. There's National Alliance of Caregivers. There's VA caregiver support, which is it's not just VA specific. And if you are specific to caregiving in India, the Caregiver Saathi group in India is a really terrific resource as well. So I just want to end with this quotation. There are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. So with that, I'm going to just put up my contact information and turn it back over to Mina.
Thank you so much for this important information. And chronic illnesses are increasing, but also managing the condition is becoming more and more difficult. Very important information, as caregiving is joyful and also can be stressful. And so while we are taking care of others, it's very important to also see how we can take care of ourselves. So thank you for sharing that information. There are some questions which are submitted, and I'll go over the questions so that you can answer them. There was the first question, which was in the chat, was, is there a hotel or apartment for short-term stay that hospice patients can go and stay for short-term besides their homes?
There are respite care places. I don't know if there's hotels. There are places that you can do respite care and overnight care. I don't know how get the information. But the Sukham group actually is a good place to start, or maybe you can look into Stanford might have some resources around that. There's area services that serve those communities or those needs. A lot of times the respite care is also available for people to come to your house so that you can get respite. So sometimes the patient themselves are not able to leave the home or don't want to leave the home, but they still need care and they need supervision. But people can come in and have get respite from that too.
Thank you. The next question was, are there nursing aides of Indian companies aware of that can help provide care?
I don't know if there's entire companies. I think the few resources again that come to mind are Sukham is a good resource to check out. There's also Aging 101 that is run by Dr. Rita Ghatak. She probably has a lot of her organization probably has a lot of those connections, because that's what a big part of what they do is they help with their focus is dementia caregiving, but a lot of the things applies to all kinds of caregiving. So they might have more the lists of people who have the Indian descent. Rita Ghatak, Ghatak, and it's Aging 101 is, I think, the name of the company, her company. I also just want to say that the Stanford has an Stanford Caregiver Initiative, and they have a Stanford resource in 500 Pasture Drive. They have a library. Maybe Jillian or somebody who's more familiar with it can speak to that. But they have really great library resources in that place, and there might be other resources that if you're connected to Stanford, if you're a Stanford patient or your patient is a Stanford patient, you might have access to that too. And I think thank you, Nina. Nina just put a health library resource. Thank you. It's called the Stanford Caregiver Center. Thank you.
And they were asking if you could repeat the doctor's name again.
Yeah, I'll put it in chat.
Okay.
I'll put it in everyone. The
And then we have some pre-submitted questions. How should one approach caretaker burnout when your loved ones are in need?
This is a very, very common issue because the care recipients' needs often only increase. It's very, there's a lot of conditions, things either are stable or are just generally deteriorating. So once ideally, we would recognize that we would do a lot more things to prevent burnout, like taking breaks, finding other resources, all those things, which always sound far easier to say than actually to do, especially if you're the one person who the care recipient trusts, or if the care recipient doesn't speak English, for example, and they need somebody to constantly translate. If you start experiencing caregiver burnout, it's very, very important that you get the help that you need. So whether it's a support group, whether it's talking to a mental health professional, somebody who has an expertise in caregiver burnout would be ideal. But also talk with the care recipient's healthcare team, so your loved one's care team, and let them know that you're struggling, and it's nothing to feel bad about. It does not mean you love that person any less. These are really, really difficult situations. And what happens is that more and more keeps getting added. And if you're lucky enough to have a case manager, a social worker as part of the care team, they can really help you figure out other resources like home health aid or nursing aides, or there's also people, you can get stipends through some of the federal and state policies, like the Medicare, Medicaid, to care for a family member. So there's ways that you can get additional help that could help out. But the most important thing is, if you're already starting to feel burned out, talk with your doctor and talk with the care recipient's care team, your loved one's care team, and let them know. And they will will have heard this before already, and then hopefully they'll have some solutions for you.
Another question is there any research on how Asian American family members and patients perceive palliative care in hospital settings? This is from a clinician and a professional interpreter. And she finds that in business model and the way they are trained make it such that the medical professionals tend not to respond in a way that addresses their needs, particularly when it comes to being emotionally responsive. So again, the question is there any research on how Asian American family members and patients perceive palliative care in hospital settings?
That's what we are doing. So the project was actually funded by Palliative Care Foundation. Not a lot, and not as much. I can speak to more to the South Asian literature. There's a lot of services that people are present, but in general, palliative care, hospice care, end of life care, pain management, those are things that are not really well studied. The research that my colleague Carl Lorenz is doing, and Carleen Gianna Trapani, they're doing, that is based in India, they're doing more training palliative care providers, training people to provide palliative care in India, and working with the Pallium group, which is Dr. Rajagopal's group in Kerala, to work with them. But the research is very, very limited in these things, because again, these are very taboo conditions. And it's actually, I did not report our provider interviews, but we interviewed providers about this and asked about how they feel providing culturally attuned care to South Asian patients. And one of the things that they brought up is actually, it gets complicated when the families don't want to disclose that some like serious diagnosis like cancer to the patient. And of course, the provider, healthcare provider is like, well, we have to disclose, like that's how we provide care. Or if they say, well, no, the patient is asking for pain medicine, and the family says, no, we want them alert, and this is not, we don't want them to have opioid pain medicine because it can be addictive. And so providers actually really find themselves caught in the middle of these conversations. And again, in the palliative realm. So these are really questions that need to be well stated, well understood. And if the person who asked that question is interested in collaborating, please reach out to me. There's enough work to go around. These are big problems we need to address.
Absolutely. Next question is, what strategies are there that clinical teams can implement to better include caregivers into the clinical care, especially when there are 9+ caregivers involved?
Sorry, can you repeat that question? I got distracted by the chat.
What strategies are there that clinical teams can implement to better include caregivers into clinical care, especially when there is a big number of caregivers which is involved?
Yeah, I think these are really, this is kind of goes toward the vision of culturally attuned care. I think that the important first thing is to find out, who does the patient want to be involved? Right? Because I think when we keep the patient front and center, that can be really helpful from a clinical perspective. And that question has to be asked in private, obviously, because this is patients' families, and these get complicated. Then you need to make sure that the person who the patient has anointed, that person knows that they're the main person. And then this different discussions need to flow through that. And then you might need to work with a case manager or somebody with that specialty to work out some kind of communication plan. Like, so what are the needs of these 8 people? Is that they want to be involved with every aspect? They want the information, they want to do all that. And I think it will take a lot of effort and resources, but I think to provide truly patient-centered, family-centered care, that's an effort that we as clinicians, unfortunately, will have to shift our paradigm to do it. But the advantage of that is that the patients feels like their needs are being taken care of. And then once there's a point caregiver, then it can be that person's responsibility to communicate with the other people and channel the communication to the healthcare team.
Perfect. Another question just came in. Any resources or insights relating to younger Asian American adults with chronic and serious illnesses? They and their caregivers, middle and older adults, may face particular stresses, especially disruption in expected roles.
I think I see what you're getting at. So the older person is caring for the younger person.
Correct.
And so now it's kind of flipping that intergenerational care. I think there's a lot of research in this, not specific to Asians, and I'm not familiar with this particular dimension of research, but outside of the Asian culture, just generally, there's a fair bit of culture, parents caring for kids with chronic conditions like diabetes or developmental disabilities, congenital diseases, cancer. And so there is a fair bit of research out there. A lot of these are not well researched, but I would say if you are somebody in that position where you are experiencing that, sort of shift in script, I would say, recognize it as a kind of grieving, right? So it is a kind of grief that we experience when we see our next generation not thriving the way we had imagined. And it's absolutely reasonable to then talk with a psychologist, to get somebody to help you process what that looks like. Talk with other parents who are in a similar situation, even if it's not the same condition. Because parents often feel that they feel that this is not how it should be. Whether it's because they felt like, who's going to take care of me, because we thought that's what the kids would do. Sometimes the kids wind up dying before the parents, and that also seems, like you're flipping the script, and that's not how the order of the world should be.
And many times I feel there is some discomfort when it comes to if the younger you know person is sick, and if the parent has to take care of the younger person, that I think so that transparency probably doesn't happen as much, because the younger person is probably feeling, should I be telling my dad or mom to take care of me, or the elders to take care of me? And I think so that becomes difficult.
Yes, absolutely.
Um, there is another question. I encounter issues related to the family members not wanting to disclose the cancer or any terminal illness diagnosis due to cultural beliefs and medical professionals not understanding that. I would love to be able to help in any way with getting involved in the research related to palliative care and sharing my own experience and observations as a clinician in professional interpreter in palliative care. So,
Yeah,
uh,
I think it's Sonia. Yeah, definitely. Just email me at ranak@stanford.edu, and we can and tell me a little bit more about your background, and we can take it from there. Happy to talk more.
perfect. Those are the questions I have so far. Um, I have one more question, which I have from the questions which were submitted earlier, and how can we best support caregivers and understand their challenges without framing those people in need of care as burdensome?
Um, the way we have approached it in our work is basically talk about that any chronic illness affects the patients and caregivers both, but in different ways. So it may affect the patient in the way of, changing their quality of life. Maybe they might not be able to do as many things as they used to. They're more worried, they have to change their lifestyle, but that the caregiver is affected as well. So it's not so much that the care recipient or the patient is deliberately making it harder on the caregiver. It's that they're both affected. It's a stressor. It's something that is a stressful situation that is affecting more than one person. And I think keeping that framing can be really helpful for the patients to not feel guilty, because a lot of times patients feel guilty. They feel that, gosh, if it wasn't for me, you'd have so much more time. We'd have so much more money. If my health
Mhm.
wasn't like this, you wouldn't have to quit your job. And I think these are tough conversations. One of the things we've been doing is we've developed an intervention that gets patients and caregivers to have these conversations, to get them to sort of see each other's perspectives and be able to communicate and so that it actually can serve to strengthen their relationship. So these are all opportunities also to strengthen the relationship. And I think the other part, the burdensome thing is, I think we also need to recognize that just because somebody is sick, even very, very sick, doesn't mean that they don't have value or that they can't
Mhm.
contribute, right? And so I think there's this sort of idea that, like an ableist idea, that if you're disabled, that your worth has dropped. And I think that is very pervasive, unfortunately, in our society. So I think that becomes more of, I think where we as a society need to shift our perspective to think about people as not just um, in terms of their ability to earn money or do their physical ability, but also to continue appreciating what they have to offer, and then creating a place where they feel like they can contribute, so they don't themselves feel like they're a burden to a person or to their communities.
Perfect. Thank you. Um, Thank you for all the great answers, Ranak. And I don't see any other questions coming in, but uh, if there are any other questions, if there is anything else which you would like to share with our audience, feel free. But those were kind of the questions which I had on the chat.
I think this is because this is recorded and people have access to it, but if somebody is looking for specific resource that I put up and you missed that slide, or if you need a way to contact, just email me. But I'm happy to send those resources your way.
Thank you so much for all what you do, and thank you for Thank you for this excellent presentation, and have a good evening, everybody. Take care.
Thank you for moderating, Mino.
Okay, take care,
Have a
Ranak.
good night.
Okay, have a good night.